So again, thank you guys for coming tonight. It's a beautiful evening and you're going to spend it indoors with us talking about birds, bees, and sex. Well, we're thrilled to have you here. So that being said, let's go ahead and get started. Now we're going to play a game. It's called 20 questions. But the problem with this game, it's a little unbalanced because guess what? I'm going to ask the question and then I'm going to answer it. And my goal is to cover different topics related to the bladder, the bowel, and sexual dysfunction. Okay, again, I have more topic than time. So you guys have heard me before. I tend to talk fast, and tonight I'll probably talk triple time because I really want to try to get through our topic tonight. Again, the topic, the birds and the bees. And the bathroom, please. Now we're going to start with B&B, not bread and breakfast, but bowel and bladder. And so why we're going to start with this is because it's a little bit less sensitive of a topic, and so maybe we'll kind of warm you up for the talk about sexuality. All right, so just as a way of introduction, symptoms of MS are never, ever the same from person to person. Okay, so although we talk about symptoms in a global fashion, they always have to be individualized to that particular person. Not only that, they may change, not only from month to month, but over the course of the disease or over the course of a relapse, they may change. They may go away, but they may also be long-lasting. And I'll say that's true with almost every symptom of MS. And so not exclusive just to bowel, bladder, and the sexual dysfunction, but particularly in the midst of a relapse, if people are having symptoms, there's a high chance that those may go away and may not resurface again. But then they also may resurface in the form of a pseudo-relapse. Now, I don't know if anybody got a chance to read the newsletter article, but we categorize in our practice and throughout the medical field symptoms as being primary, secondary, and tertiary. And that is primary symptoms have the direct effect related to a breakdown, in the case of MS, of the central nervous system. So the central nervous system has an error in messaging in it, and there's a direct effect of that. That's a primary symptom of MS. A secondary symptom is that primary symptom may be affected, but the real problem is not related to that, but related to a secondary symptom of MS that interferes with the primary function or the primary problem we're trying to address. And tertiary is that out in the fringes a little bit. How does this symptom that we're dealing with, whether it's the primary and or the influence of the secondary to the primary, influence more psychosocial impact? How does it influence me as a person? How does it influence my family unit? How does it influence the extended family? How does it influence my work environment? How does it influence my finances? And how does it influence kind of who I am and the community at large and how I interact in not only the work environment within the community? And we'll go through some specific examples of that through the presentation. Okay, so first question, how does the bladder work? Now I think this is a good foundation because we have to understand normal before we can understand the problems that are prevalent in MS. And so here's a fancy picture. It has some anatomy attached to it, but when I talk to people in the exam room, and I do a fair number of bladder assessments, I want you to think of it like this. I want you to think about your kidneys are sitting up here, high on your back, and they're doing their job. And their job is to filter out toxins and pull out water or extra fluid from your circulatory system, okay? We could go into how that works, but that's not our topic tonight. So those kidneys are doing their job. They're gonna have urine drip down long tubes, longer than what's pictured in this picture, called ureters. And the ureters end, and there's one on each side, in the bladder muscle, in the bladder itself. And I want you to think about the bladder like a deflated balloon. And as the urine drops down into the balloon, it stretches out. Drip, 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 okay? As that bladder muscle wall stretches with that full urine, what happens is, if everything works the way it's supposed to, you get maybe a half full bladder, and what happens is that bladder muscle sends a signal back out, up through the spinal cord, through the brainstem, to the front part of the brain. And once you're potty trained, because that's the whole deal, getting that front part of the brain to take control over the reflex of urination. Once you're potty trained, what should happen is you should say, oh, I got a little while, I can wait a little bit longer, I'll wait till after Mary Kay's finished before the next break. Or, oh, I better start thinking about going to the bathroom. Especially because I know it's all the way down the hall and I don't walk as fast as I used to, so I better think about going. Or, oh my God, I should have gone to the bathroom before Mary Kay started talking. Now again, that's if things work normally, okay? And I consider that an up message. Now, what also happens once we're potty trained is the front part of the brain takes over, quite literally the frontal lobe, takes over, and you get to the bathroom, and you sit down on the toilet, and I'll tell you what, I don't have any idea why I ever taught those boys to stand and pee. You know, they can throw a baseball through a hole this big, but they can't hit that water. I just don't get it. So you get positioned, and what happens is that front part of the brain takes over, sends the messages back down the same pathways, through the brainstem, through the spinal canal, and out into the bladder muscle wall itself. But this time, the message goes to two different places. One is the sphincter, and the other is the bladder muscle wall. And so if things work the way they're supposed to, you're positioned on the toilet, or standing next to the toilet, and the valve opens up, and the bladder muscle gets the message to squeeze tight, okay? This then relaxes, and you start the whole cycle all over again with an empty bladder. What you drink takes about 2 to 3 hours to go through that whole system, okay? Which is going to be important when we talk about management. Now, do we get the picture? Okay. What kind of problems do MS patients have related to their bladder? Well, if you understand that picture, it's really easy from here on out, okay? The parts and pieces work fine. It's the messaging that's messed up and interrupted by lesions along those pathways. And most typically in the upper cervical cord in the pons, because there's a relay station there, and those messages get delayed or interrupted. Now, there are 3 major types of problems. Failure to store. Now you guys know what that is. That's when your bladder barely fills up and you get the message, oh, I gotta pee, I gotta pee, I gotta pee, I gotta pee, I gotta pee. That's what you see on the commercials that are on TV, okay? The medical name is called hyperreflexia, all right? The next type of problem is failure to empty. So what happens is exactly the opposite. Your bladder fills up and fills up and fills up and fills up, and you never register a message that you have to pee, okay? That's called a hypotonic bladder. So it fills up, and possibly you don't ever get the message from the bladder itself, but from the pelvic pressure and the pressure on the other organs saying that, oh, I better head to the restroom, okay? Now, the other one is a combination of the two. It's called failure to communicate when I talk about it, but the fancy name is called detrusor sphincter dyssynergia. And it is really a little bit of a combination of both of those. I consider this one, again, more a down messaging error. So you may fill up appropriately, and then what happens is when you go to head to the bathroom, the valve opens up, and you leak a little bit on the way to the bathroom. Okay? You don't want to totally wet yourself, so you close it off intentionally, and thanks to Carla, she'll help you do that effectively. And then you sit in the toilet and you can't go. Oh my God, you wiggle and squiggle, and I said, I know I have to go, I just got that message that I had to go to the bathroom, and you can't get started. Okay? Then what happens is you finally get started, but guess what? This doesn't squeeze very hard because this squeezed hard when the valve was closed up. Okay, and so there's this disconnect, this uncoordination or discoordination of those two parts. And what can happen is, one, the symptom of that kind of thing is you're in the bathroom all the time because you always have a bladder that's half full, because you never are able to totally drain your bladder. Okay, so that is the three major buckets we put our bladder dysfunction in. Third question, well, I have to urinate all the time. What is wrong? Well, based on what we just talked about, it could be any of a number of things. Failure to store, you're going to get in there all the time, and you're going to the bathroom every half an hour or every hour, but guess what? In this case, you probably only feel like, and you probably only urinate a thimbleful, okay? Failure to communicate, you just saw how that can happen, and if your bladder's always half full, guess what? You start with a message already saying you got to go to the bathroom. And so you feel constantly like you got to go to the bathroom, and you always have not only that urgency, but you may have urge incontinence. You may leak on the way. And the other thing that influences us is infection. And there will be a slide on infection also. But that also is a symptom of infection, urinary tract infection, is feeling like you need to go to the bathroom all the time. Okay? So, question number 4. What is a bladder scan and who cares? Well, I'll tell you, this is one of the most valuable pieces of equipment I use within my week in the center because it helps me understand which problem I'm going to deal with. And a bladder scan is a simple ultrasound that measures the amount of fluid in the bladder in real time. Okay? And I always say if I see a baby in here, we're both in trouble. So what it does is it's just a little probe that you use some gel on and you find the bladder and it measures the bladder volume. Now I use this tool to help me prior to the time you go to the bathroom because I want to see if you're just a little bit full or if you're really full before you get the urge to go to the bathroom. And then I'm going to have you urinate and I'm going to see how much is left, okay? So that I can get an idea, is it failure to store, is it failure to empty, or is it one of those combinations that the detrusor sphincter dyssynergia? Now, you said, Mary Kay, I've never even heard of that thing. My doctor told me I had to go get a urodynamic test. Well, a urodynamic test is like the Cadillac of bladder assessments. It gives us a whole lot more information than just a simple bladder scan, but it is more invasive. It can tell us things like your bladder capacity. It can tell us the strength of your stream. It can tell us where you get that urge to void. It tells us the velocity of the contraction of not only the valve and if there is spasticity within that valve and or spasticity within the bladder muscle wall itself. Okay? And of course it's going to tell us the residual volume, which is probably the least important information when we're talking about a full-blown urodynamics test. We really want to look at all the rest of that to make sure that we're on target with our assessment of the problem related to MS. Okay. I find I get into the bathroom and I can't go. What's that all about? Well, technically that's called hesitancy. You have urinary hesitancy. You feel like you have to go and you can't get it yourself to empty. Now, most often that is with a failure to empty situation. Remember that the hypotonic bladder that gets so big that you just can't get it to empty, or DSD, detrusor sphincter dyssynergia. Again, can be related to infection. Now, hesitancy itself is not necessarily a problem. It's a symptom of that mismessaging or that lack of messaging traveling up and down the spinal cord. When it becomes a problem is when you have urinary retention, not able to avoid in a period of 12 or 15 hours. That becomes somewhat of a crisis and an emergency because guess what? God was smart, but sometimes I think, wow, there is no back valves. So the bladder's here, the ureters are here. There's no back valves into the kidneys. And so if your bladder is full and it's not coming out the end, it could potentially back up and cause kidney failure or renal failure. Okay, and if you walk around with a really full bladder and you're not able to empty all the time, that is one of the dangers. And we'll send people occasionally for renal ultrasound to make sure there's not been some chronic damage related to that full urinary retention. Okay, and we tell people if they can't go and it's after hours, you get yourself to an ER if you need to, or an urgent care if they're still open, because that really can be dangerous. Okay, what can I do to best manage my bladder? Kind of the crux of it. Well, it really depends on the problem. Okay, failure to store. And I didn't list them because the list is almost as long as my arm these days. We use antispasmodic agents. And those are drugs that people can take to help this bladder muscle fill up a little bit fuller and stretch out a little bit more before that message starts the system. Okay? We also use some tricyclic antidepressants. And again, it has an effect on that smooth muscle within the bladder itself. We'll use a medication called DDAVP occasionally. And this is a medication that actually, again, with failure to store, prevents urine production, and we use it at nighttime. Okay? Occasionally, people are candidates for Botox. Now you say, Mary Kay, my wrinkles, what about my wrinkles? I know, but Botox in the bladder is actually a very effective treatment. And so here's how that works. Remember, you got this bladder that's barely filling up, and you're continually having to go to the bathroom. And what a urologist can do, not in our office, what a urologist can do is actually do a cystoscope and inject Botox in the bladder muscle wall itself, so it freezes that bladder muscle wall so you're able to fill more full and not have the frequency of going into the bathroom and peeing a thimbleful every hour or so. Again, that's a treatment for a very niche group of people. The downside of Botox is that if you don't know how to do clean intermittent self-catheterization, you need to learn that so that you never get into a place of hesitancy or retention where you can't go at all, because occasionally that bladder muscle will freeze totally, and the only way to empty is by catheterization. Now, I will tell you, we have some patients that want it that way. They don't want to have to leak in between. They don't want to have to think about it in between. So they let their bladder get pretty frozen with the Botox. And so they are just using catheters 4 to 6 times a day to empty their bladder, and they never have to worry about leaking in between. So again, that's another option. External catheters are also an option that's less invasive for failure to store when you feel like you're going all the time and you just, especially if you have a lot of mobility problems, having trouble getting to the bathroom and using a whole lot of energy to get to the bathroom. External catheters are an option. They work pretty well for men if we can find the right type and size and things like that. There are external catheters for women, and they tend not to work as well. That's been our experience. Okay, so failure to empty. Remember, this is where you don't ever feel like your bladder is full, but it's full, and you look at the clock and say, oh, I haven't gone to the bathroom since I woke up this morning at 6:30. So what do we want to do here? What we want to do is a couple of different things. One is we can use medications that help the bladder muscles squeeze tighter, okay? And those actually work fairly well. They're just a pain in the neck to take, because you have to take them 3 times a day on an empty stomach, okay? We also will use medications that help the valve relax. I didn't put that up there, but you know, sphincter tone medicines that help that relax. And these are sometimes used in the male population for benign prostatic hypertrophy. And so it helps that valve relax, and so that stream can be full and you can empty all the way. So things like Flomax we'll actually order for women sometimes, which is a medication specifically for men, and the pharmacists always call me and say, Mary Kay, do you know this is a guy that's you're prescribing this? I mean, a woman you're prescribing this to? Yeah, I do. But also, we've had some pretty good success in the male population with daily Cialis. Again, helping with that relaxation of that valve for bladder control. Indwelling catheters is also a way to manage failure to empty, along with clean intermittent self-catheterization, and also suprapubic catheters. So the difference between that is the indwelling catheter goes through the urethra between your legs or through your penis into the bladder muscle wall itself, or into the bladder itself. The suprapubic catheter goes through the stomach into the bladder muscle itself. Both of them drain to leg bags and or night bags, so that, again, people don't have to manage getting to the bathroom all the time. That there's a constant kind of drainage system for them. Okay, medications to help with failure to communicate. Really, the list depends on what I see in the assessment. If I see some of that bladder spasming stuff, we may try some of the antispasmodics. If we see a full bladder after void, we may use some of the medications that help that bladder muscle squeeze itself. Ultimately, though, the best way to manage failure to communicate and failure to empty is some type of catheterization. And people freak out when I say that, you know, oh my God, I'm not going to try to learn that. But really, many people with either an indwelling, a suprapubic, or clean intermittent self-catheterizations find their life very liberated because they're not slaves to the toilet anymore. And they have more control not only of their bladder management, they also may have control of their bowels because that bladder's not constantly full pushing on the bowels, and they have more energy because they're not using their energy to transfer on and off the toilet all the time. Now, what are some of the things not kind of invasive that we can do? Well, healthy fluid intake, 64 ounces of fluid a day. Now, hardly anybody drinks that, so when you see me, I'll say, let's start with 32 and see if you can get that. Drink in bulk. I don't know how else to say that. Bolus might be another word. But again, if you sip all day, you're going to pee all day. So drink, take a break, pee, drink, take a break, pee. But I just told you I want you to drink a lot. So you got to drink a lot when you're drinking. Timed voids is very effective. And there's a reason we did that when we were potty training our kids. We were training our brain. And remember, the messages aren't getting up there now. So we're going to try to retrain our brain again. And so I tell people, look at the clock. Every 2 hours, I want you in there trying to go to the bathroom, whether you've gotten the message or not. Pelvic floor exercises, which Carla's going to talk about, and occasionally people will have some biofeedback success. Again, trying to train their bladder. All right, we're only on question 8. I better move it. What are other things I can do to help me void? Again, address the secondary concerns. And primarily when we're talking about bladder and bowel issues, that's removing the barriers. Make sure you don't have 501 button-up jeans on if you can't get to the bathroom fast enough but already. Plus, you're going to have to spend all that time getting your pants down. Okay, mobility is an issue. So do whatever you can. Take the throw rugs out. Get the walkers out if you need to get to the bathroom fast enough and safely. And then again, tertiary things. I want you to consider again the social effect of having an accident. And so for those who might be loved ones of the person with MS, they may want to limit their social activities, and we have to understand that. Everybody knows where the restrooms are, in the front of the Walmart store and then in the back of the Walmart store, right? There also is a financial concern related to bladder management and, again, bowel management. Adult protection is expensive. And so that is a financial concern. There also may be a change in roles. So all of a sudden your loved one who you love dearly is now helping you on and off the toilet 15 times a day, and that just doesn't feel like the right kind of relationship to have. So all those issues need to be addressed along with kind of the primary mechanism, like we said. Okay, what is double void? I call it the stand-up, sit-down routine, okay? You go, you stand up, you think you're finished, and you have to sit right back down. Now, this is often a number one tale for me of failure to communicate, okay? That messaging keeps going, but you're not able to empty your bladder all the way. I would say take advantage of that. If you need to sit back down and go again, it's because there's more urine in your bladder. We also want, again, to use some external pressure, called external cordae, to help, again, make each void as successful as possible, and consider timed voids, as we said. Okay, I tend to get UTIs frequently. Why? Well, again, it's all about the messaging and keeping urine in your bladder. If you always have a little bit of urine or even a lot of bit of urine in your bladder, that's a great growth for media for germs to grow. It's often failure to empty or failure to communicate with residual, but we also have to rule out other causes. Okay, so a woman that has a chronic vaginitis may also have frequent urinary tract infections. Somebody that's blood sugars are not in control may also have frequent urinary tract infections because they're spilling sugar, and germs love sugary places too. So how do we address this? Again, we want to make sure that we're catching it because it's often not the typical symptoms of pain, burning, and blood. It may be a change in urgency, a change in frequency, or a change in urge incontinence that is the trigger that there might be what we call a subclinical infection. So we want people to drink plenty of fluids, put cranberry pills so they change the acidity of your urine, avoid bladder irritants, and again, one of my goals is that you always get your urinary care in the same place. Okay, so if you go to an urgent care because you think you have a bladder infection, if you go to the gynecologist because you think you have a bladder infection, you go to your primary care because you think you have your bladder infection, the next one you call the neurologist because you know they'll call you back right away. Now you've had 4 infections and not one person in that cycle's known that you had 4 infections in 5 months. Okay, so be consistent in who you pick to manage your bladder. I get up and go 2 to 3 times a night. Is this normal? No. Sorry. Again, what you want to do is avoid fluids before bedtime, void before you go to bed, if you're cathing before you go to bed, adjust the timing of your medicines, consider talking to your doctor about DDAVP or the desmopressin that may decrease urine production at night, and there are some caveats. It's not absolutely the safest drug to use. But also make sure that you can get to the bathroom quickly and safely and get back in bed so that you can get back to sleep and not interrupt your sleep cycle so much. Okay, how do I learn to clean intermittent cath? I've talked about that a lot, and once you get over the psychological barrier of that, it's actually a pretty easy technique to do, and it doesn't really matter where you learn it, as long as you learn it well, and that can be in our office. It could also be with a urologist. Home care comes out and teaches people how to manage that. You can learn how to do it if your hands don't work or your legs you have too much spasticity. A spouse or a significant other can learn it. There's tricks of the tray. We're not going into those tonight, but it does take practice. It's a skill, and it takes practice. And then if you're not successful, go back to your healthcare provider and discuss alternatives. Okay, well, where do I get catheters? I only threw this slide up because I will tell you, despite all the bad things that have happened in the government and insurance in the last 5 years or so, of late, Medicare will pay for a single-use catheter. For years and years and years, they would say you could only have 1 catheter to do clean intermittent self-catheterization per month. And so we did make a little bit of progress there. That's for the kind of the typical catheter. If anybody's been to any of our vendor displays where 180 Medical or Coloplast are there, you could see there's as many catheters as brands of cars on the street. And so you can get some samples of those and try different ones and figure out what works best for you. And then you'll have to figure out if there's a cost difference between what your insurance will reimburse and what the cost of that catheter is. Okay, if I have an indwelling or suprapubic catheter, how do I care for it? Well, just consider it a kind of a wound or something into your body. You want to clean it daily, no special thing. You need to change it every 3 to 4 weeks or have it changed. Some people consider prophylactic antibiotic use. We usually don't do that within our center unless we need to. But there is a special procedure for rinsing the night bag and the day bag, and that needs to be taught to you if you don't know how to do it. People will ask me, well, can I have sex if I have an indwelling catheter? Well, the answer for females is yes. You just move it out of the way. The answer for males is no, not in the typical penile, vaginal kind of sex way. So yes, you cannot. Now, suprapubic catheters, yes, that's not interfering with any of the other parts and pieces. And people can swim with catheters. You just have to clamp them off and be taught how to do that. All right, why does the MS nurse always ask me about my voiding when I call and say my legs are stiff? Well, that's because bladder infections are usually the #1 culprit in an acute change in spasticity. And it's the infection that slightly raises the body temperature that causes spasticity. So if you've noticed your spasticity is worse and you can't figure out why, that might be the first thing you think about. Do I have a bladder infection? Now, what is stress incontinence? Well, it's a change in abdominal pressure. And again, it may be a sign of prostate problems, and not all problems are related to or can be blamed on MS. Okay, look, question 17, we're getting there. Do we have to talk about bowels? Well, yeah, because it's common. And again, here's why. Those nerves, remember I showed you that picture? Bowel, bladder, and sex nerves run right next to each other in the spinal cord. And so it may be very typical to have problems in multiple areas if you have problems with one. The most common problem related to bowels is constipation, but there can be fecal incontinence, diarrhea, or gas. If I go once every couple weeks, is that enough? Probably not. Probably not. But we're looking for a goal for people that are severely constipated, 2 to 3 good bowel movements a week. Okay? Again, typical things here that you've learned from way back when. I will tell you though, the one fault I hear about all the time is, I sat on the toilet for an hour and a half and I still couldn't go. Well, shame on you, first of all, for just sitting there and wasting that much time on that. But again, it's because the urge isn't there, and it's that messaging problem. It will also take 2 to 3 months to establish a good bowel routine. So patience is needed in this realm. Here's some interventions. We start at the lower step and work our way up, okay? We want to think about food, fiber, diet. Again, we'll then talk about stool softeners or laxatives and then move our way up. We'll say some people have, it's not common, but I have heard some people get a colostomy to manage their bowels so that they could stay in their home, because they could manage their belly, but they couldn't manage fecal incontinence. So that's really the top rung. But really we want to do, same thing, address those secondary concerns. #1 culprit of constipation is the medicines we give you. All right, so got to look at that med list. Most all those bladder medicines I talked about cause constipation. And so it's doubly important to make sure you're getting enough fluids, make sure you're exercising, and again, we want to address mobility, dexterity, and the whole kind of tertiary symptoms. Question 20. So again, not all bowel problems are related to MS. People with MS still get irritable bowel syndrome, diverticulosis or diverticulitis. They may have polyps, they may have cancers that we have to address. Okay, now, do we want to go on for bonus round or do we want to stop?
Bonus round.
All right, so sexual function. Again, primary, secondary, and tertiary. Primaries, again, related to the nerves not working. Primary, most often spinal cord involvement. It's a loss of the signals that allows for sensation and blood flow. So if the signals aren't allowing for the sensation and the blood flow, in the female, you're going to have vaginal dryness, loss of sensation or decrease in vaginal or clitoris sensation, and trouble achieving an orgasm. The male patient, again, decreased penile sensation, difficulty achieving and maintaining an erection, and delay in ejaculation. Okay, that's the primary reason. The nerves aren't allowing the messaging to get through related to the plaques. Okay, so I don't know if you've seen this. We don't have it in our bathroom, but it might be somewhere. And let me say, if the light stays on for more than 4 hours, call an erectician. Okay, both men and women with MS suffer from a loss of libido. And this, as you see, is a secondary symptom. It's not related to the messaging. It's related to anxiety. It's related to depression. It's related to change in roles. It's related to change in your sense of self and your self-esteem. It's related to your altered body image, and It's related to the fear of failure. And again, fear of failure freezes people usually before this, the sex acts can even become carried out. Okay, secondary, and again, Carla and Heather are going to address this a lot, but fatigue, spasticity, pain, bladder leakage, fecal leakage, all get in the way of wanting to have our ability to have traditional sex. And those all need to be addressed so that if we can get you pain-free, we can get your spasticity relieved, if we can get your bladder empty before you have sex, it's going to be more pleasurable for you. So you have to talk to your healthcare provider. And sometimes we're not the best at bringing these up. So if this is top on your list, put it top on your list and let's talk about it. Now, tertiary is all about the relationship, okay? We have to value sex, we have to value the relationship, and we have to want to talk about it. It's about open and honest communication. It's about recommitting to the relationship. It's about exploring something new. These girls are making me laugh in here. And remember, sex isn't always a physical act. Sometimes it's the intimacy that's involved. Okay? I say this a fair amount. My husband hasn't heard it though. Sometimes I'd rather him rub my feet than have sex. Again, you want to make sure that you talk to your healthcare provider and talk to somebody that's specialized in this topic. Okay? All right, I'm going to read this to you. What is celibacy? Celibacy can be a choice in life, or it can be a condition imposed by circumstances. While attending a marriage weekend, Frank and his wife Anne listened to the instructor declare, "It is essential that husbands and wives know things that are important to each other." Okay? She then addressed the men of the group, and she said, "Can you name and describe your wife's favorite flower?" Well, Frank very lovingly leaned over, patted Anne's arm, and he whispered in her ear, "Gold medal all-purpose, isn't it?" Again, that became Frank's life of celibacy. All right, thank you guys.